Hello. This is a lecture in Module 10 under the category of vaccination in immunocompromised populations, and this talk will specifically focus on travel patients. My name is Rubin. I'm a pediatric infectious disease specialist in New York, and I'm at the Cone Children's Medical Center of New York, part of Northwell Health, as well as the Hofstra Northwell School of Medicine, also in New York. We'll jump right into the topic and ask why vaccination of transplant patients are important. I should digress for a moment and say there are really two different types of transplant patients. One is solid organ transplantation, and the other is hematopoietic stem cell transplantation, sometimes called bone marrow transplantation. In both of these populations, appropriate vaccination is important for several reasons, including an increased risk for exposure because of the frequent association with the medical environments in these significantly ill children. And that would include the potential for exposure to persons with influenza and varicella. Furthermore, there can be increased risk if a vaccine development there can be increased risk if a vaccine-preventable infection develops. An important example would be a pneumococcal infection, which could result in severe sepsis in such patients, particularly those with graft versus host disease, and also these patients that are increased risk for developing vaccine-preventable infections. So an increased risk of infection and an increased possibility of severity infection. And it's important to compare and contrast stem cell and solid organ transplant patients because they, in each case, there's a differing risk of infection that changes over time. So first I'll just mention some of the timelines for solid organ transplant. For these individuals, it's divided into three time periods, the first being day 1 through 30 after the surgery for the solid organ transplant. The most important infections during this period of time are bacterial infections, which might include surgical site infections, the anastomosis where the transplanted organ is connected to the host, as well as vascular catheter-related infections, including bloodstream infections. After the first month, from the day 30 to 180, then these individuals are in an immunosuppressed state due to the presence of drugs to prevent rejection, which may include corticosteroids. And there is an impairment resulting in impaired cellular immunity. Primarily opportunistic pathogens are of the most concern during this period, and that would include the virus, cytomegalovirus, which may be reactivated or infected via the transplanted organ or possibly via a blood transfusion. The fungi, pneumocystis, and other fungi can be important, as well as toxoplasma and nocardia may cause infection, reactivated infection typically. And finally, 6 months after solid organ transplant, regular community-acquired infections that could happen in any individual are important, but also the reactivation of latent viral infections can occur, including zoster, a reactivation of the varicella zoster chickenpox virus, warts, Epstein-Barr virus-induced lymphoproliferation. And the risk of these will vary with the degree of immunosuppression, so that there are solid organ transplant patients that have very mild immunosuppression after 6 months, or some that have significant immunosuppression because of the medications to prevent rejection of the transplanted organ. If we switch gears and talk instead about stem cell transplantation, also called bone marrow transplantation, the most important concept to understand is that the initiation of the procedure starts with immune ablation. So this could be with very high-dose chemotherapy, this could be radiation, but it leaves the patient in an immunologically naive state, much like a newborn. And like solid organ transplant, This is the time after stem cell transplant is often divided into 3 periods: the pre-engraftment period, the early post-engraftment period until day 100, and the late post-engraftment period after day 100. So the pre-engraftment period is after the ablative therapy that renders the patient neutropenic, and until that neutrophil count returns. And during this period of time, the patient is at increased risk for bacterial infections and one fungal infection in particular, namely Candida, as well as herpes simplex infection. For many of these infections, prophylactic antimicrobials are prescribed. In the early post-engraftment period, after the neutrophil count has recovered, then patients are at risk for the fungal infections Aspergillus and Pneumocystis, as well as several different viruses, including adenovirus that may cause a hemorrhagic cystitis, a cytomegaloviral infection that may cause pneumonitis, as well as leukopenia, neutropenia, and thrombocytopenia, and varicella zoster virus infection. The risk factors for these infections are the lymphopenia that these patients routinely have and the impaired cell-mediated immunity. And finally, in the late post-engraftment period, the most important organism is pneumococcus, particularly if the patient has chronic graft versus host disease, as well as the immunosuppressive treatment used to treat chronic graft versus host disease. With that as background, we'll review issues related to vaccination of these two populations. And in terms of safety issues, inactivated vaccines are of not very great concern, but of some concern in terms of effectiveness. Also, the concern of the biggest concern in safety would be of live vaccines, but also the theoretical or potential risk of any vaccine, live or inactivated, triggering a rejection episode for a solid organ transplant patient. The other issue is the effectiveness of vaccines. They're likely to be low during high-level immunosuppression, which would be in place to prevent either graft versus host disease in the case of a stem cell transplant or organ rejection in a solid organ transplantation. The effectiveness is likely to be low immediately after preparation for a stem cell transplant prior to immune reconstitution, and while on high-dose immunosuppressive therapy to prevent organ rejection. So what about the issue of solid organ transplant and vaccination in terms of the concern that it may trigger rejection? Well, there have been some case reports and small series that have raised the question of vaccine triggering allograft rejection. However, larger studies have not found an excess in rejection or significant allograft dysfunction after vaccination. And there are two important studies that highlight this to a great extent. First, there was a multi-center study in heart transplant patients which reviewed influenza vaccine in 3,600 patients, and the summary of the study was that the investigators found no differences in the incidence of rejection nor the seasonality of rejection related to influenza vaccination. Another large study that reviewed 50,000 adults who had received kidney transplants, they were renal transplant recipients, looked at the receipt of influenza vaccination or the lack of receipt of influenza vaccination. And in the study, they found during the first year post-transplant, actually receipt of influenza vaccination was associated with a lower risk of allograft loss as well as patient death. So receiving influenza vaccination was protective for losing the kidney or dying in that year following transplant, and this was with appropriate controls for other factors that may influence these outcomes. So let's look at the specific of vaccination of solid organ transplant recipients. We'll first start with the pre-transplant period, and certainly in this during this period before transplantation, a routine age-appropriate primary immunization schedules is appropriate. This would include, of course, influenza vaccine annually for infants and children 6 months of age and older. Would include a live virus vaccines, that is varicella and measles, mumps, rubella, live attenuated vaccines, but with the caveat that if those individuals are not currently immunosuppressed pre-transplant, and there is an interval of time of at least 3 to 4 weeks before transplantation, and the immunosuppression that would be started at that point. Other vaccines should be given as per the regular schedule, including Haemophilus B vaccine, pneumococcal conjugate vaccine, the diphtheria, tetanus, acellular pertussis vaccines, poliovirus vaccine inactivated, as well as the live rotavirus vaccine for young infants. For HPV vaccine and meningococcal conjugate vaccine should be given to starting at age 11. In terms of summarizing pre-transplant vaccination recommendations that differ from the regimens given for routinely for healthy infants and children, it includes the fact that pneumococcal conjugate vaccine, which is a 13-valent product in the United States, should be given starting at age 6 through 18 years, if not previously administered. Of course, for these individuals as well as healthy individuals, giving this pneumococcal conjugate vaccine is routine for individuals 5 years of age and younger. Also, a difference is that pneumococcal polysaccharide vaccine, the 23-valent, which is not routinely given to healthy individuals, is recommended to children that are anticipated to undergo a solid organ transplant starting at age 2 years of age, assuming they have not received a dose within the previous 5 years and have not received 2 lifetime doses. In addition, hepatitis A and B vaccines are indicated to any seronegative candidates, so that if a candidate has previously been vaccinated but is seronegative to either of these viruses, then revaccination is indicated. In addition to routinely giving MMR and varicella to non-immunosuppressed individuals pre-transplant, if there's at least 3 to 4 weeks of transplantation, MMR is also indicated at a younger than routine age of 12 months of age. Specifically, MMR is recommended at 6 to 11 months of age for the child, for example, a child with biliary atresia who might be undergoing liver transplantation at age 11 months, let's say. Then that vaccination with MMR would be indicated at least 4 weeks prior to the anticipated date of transplantation. The reasoning for that is that the child will be immunosuppressed following the transplant, and there may be limited future opportunities or not an opportunity for a long time to give the child the protection that the measles, mumps, rubella vaccine could afford. After solid organ transplant, the individuals, like all individuals, should receive influenza vaccine annually, and the inactivated vaccine would be recommended for this population. In addition, vaccines that may not have been completed pre-transplantation should be given, particularly pneumococcal polysaccharide vaccine 23-valent, or other non-live vaccines of the pediatric schedule. MMR and varicella may be considered contraindicated in patients that are in an receiving immunosuppressive therapy post-vaccination. However, the limited data that is available suggests these can be given safely in selected kidney and liver transplant patients. If we switch gears from solid organ transplant to hematopoietic stem cell transplant, also called bone marrow transplant, if we look at the pre-transplant status, then primary immunization schedule for children should be given, including varicella vaccine, but only if the person is either seronegative, not immunosuppressed, and there's at least 8 weeks prior to the preconditioning. Question that often comes up is vaccination of the donor of the transplant, but in general, the donor should be up to date with appropriate vaccinations for that individual, but vaccinating the donor solely or primarily for the benefit of the recipient is not routinely recommended. Post-transplant, we indicated earlier that the post-transplant, people are generally immunologically naive, similar to a newborn infant. And the immediate post-transplant period with neutropenia and leukopenia is a time where it's not appropriate to give vaccination. In general, vaccinations are not given the first 3 months after transplant. A possible exception would be inactivated influenza vaccine that can be started as soon as 1 to 2 months after transplant if there's an epidemic of influenza in the community, but generally it would start 4 to 6 months after transplantation, and a 1 to 2 dose regimen. Some of the other vaccines that you see on this slide would look very reminiscent of the schedule of healthy newborns, which would include giving a 3-dose regimen of pneumococcal conjugate vaccine starting 3 to 6 months after transplant. But in contrast to a normal individual, a normal infant who would not receive the pneumococcal polysaccharide vaccine, this vaccine should be given starting 12 months after transplant. If the patient has significant graft versus host disease and is on immunosuppressive therapy, then a 4th dose of pneumococcal conjugate vaccine could be substituted for the polysaccharide vaccine, because that is a setting in which a polysaccharide vaccine is unlikely to be effective. Starting 6 months after transplant, the individual should receive doses of tetanus, diphtheria, followed by a pertussis-containing vaccine, should receive a 3-dose regimen of hepatitis B vaccine. Individuals, again, starting 6 months after transplantation, should also receive Haemophilus B conjugate vaccine, inactivated polio vaccine, and for older individuals would be included meningococcal conjugate vaccine. MMR and varicella, being live attenuated vaccines, are indicated ultimately, but one would be careful giving them. So typically one would wait 2 years after transplantation, check serology to make sure that the individual is seronegative, and if there's no ongoing graft versus host disease or immunosuppression, then the individual can be given both MMR vaccine and varicella. The combination vaccine MMRV, which combines MMR and varicella, is not generally recommended for these populations because it has a higher content of varicella vaccine, and the safety of that higher potency varicella vaccine is unknown in these potentially immunosuppressed populations. Thank you for your attention.